Hello students, welcome to the last part of this chapter, Concepts of Care for Patients with Conditions of the Central Nervous System. So this is the last part. We learned already about ALS, multiple sclerosis, spinal cord injuries, and now what we are going to focus in this video is going to be low back pain and cervical pain. Okay, so let me get to the right place. We're going to review that one. This was a long chapter, but I would say is one of the most important chapters in healthcare. And I'm gonna give you an advice right now. When you prepare for NCLEX, try to analyze what are the conditions that are causing more expenditure, that are causing more expenses in the budget of healthcare. For example, diabetes, your endocrinologic conditions, cancer. It could be from colon cancer, breast cancer, prostate, musculoskeletal conditions, and this chapter focusing on the central nervous system, spinal cord injuries, low back, and whatever it is, the cervical pain. So these are the chapters and these are the topics that they are going to ask you the most, because you are going also the anemias, your anemias. Okay, these are the chapters that are going to the concept they are going to ask you the most in your NCLEX examination. Yes, they are going to ask you about the Hodgkin lymphoma, the multiple myeloma, but in less quantity, because those are considered like a specialty topics. Okay, so focus on the big problems, your anemias, as I mentioned, your gastrointestinal, your appendicitis, your colon cancers, your Crohn's disease, diverticulitis, all this, hepatitis, okay, all the topics. We're going to study that, and that's why this semester is crucial, because many of the topics that are causing a lot of expenses in healthcare are included in this semester. Next semester, I think you're going to have diabetes and your endocrinologist. That's awesome. Okay, but this semester I'm very happy to teach you about all types of cancers, from the gastrointestinal, the GYN related cancers, and male cancers, breast cancers, so we have a lot of work. That's why I was trying to spread all these concepts and chapters fairly in different exams. Okay, let's start with the low back pain. Is the lumbosacral back pain. It can be recurrent, or subsequent episodes tend to increase in severity. The lumbosacral lower back and the cervical, the neck vertebrae, are most commonly affected, because these are the areas where the vertebral column is the most flexible. Yes, exactly. We can do hyperextension in the cervical and also in the lumbar, right? The lumbosacral. Acute back pain is usually self-limited and lasts less than 12 weeks. If the pain continues for 12 weeks, 3 months or more, the pain has chronic back, is called chronic back pain. Pathophysiology: low back pain occurs along the lumbosacral area of the vertebral column. Let's remember we have 8 cervicals, 12 thoracics, 5 lumbar, 5 sacral, and 1 coccygeal. Okay, so acute pain is caused by muscle strain or spasm, ligament sprain, disc, also spelled disc, degeneration, osteoarthritis, or herniation of the center of the disc, the nucleus pulposus, okay? A herniated nucleus pulposus in the lumbosacral area can press on the adjacent spinal nerve, usually the sciatic nerve, okay? The one that is basically in the area of the hip and goes down uh, through the legs, okay? So that's the sciatic nerve, causing burning or stabbing pain down into the leg or foot, exactly, which in some cases can be severe. Herniated disc occur most often between the fourth and fifth lumbar vertebrae, fourth and fifth, almost at the end of the lumbar segment, right? But may occur at other levels. Okay, so we have an interesting group of pictures here. In addition to acute or persistent pain, there may be both muscle spasm and numbness and tingling paresthesia in the affected leg because spinal nerves have both motor and sensory fibers. Spinal nerves have motor and sensory fibers. The herniated nucleus pulposus, HNP, may press on the spinal cord itself. Let's remember that the spinal cord is inside the vertebrae, okay? The spinal cord. So this herniation can press on the spinal cord itself, causing leg weakness. And we remember those nerves are in charge of motor and sensory effects. Bowel and bladder incontinence or retention may occur with motor nerve involvement because sacral spinal nerve have parasympathetic fibers that help control bowel and bladder function. And what is parasympathetic? Those effects that can be that we have control. The autonomic nervous system, they can have the sympathetic and the parasympathetic. The sympathetic are most of the time the ones that we cannot control, are automatic, and the parasympathetic are the ones that we can control. Okay, so the bowel and bladder function. Spinal stenosis, which is narrowing of the spinal canal. So we have the vertebrae, we have the spinal cord inside of the vertebrae, and the spinal stenosis is a narrowing of that canal, nerve root canals or intervertebral foramina, typically seen in people older than 50 years old. The narrowing may be caused by infection, trauma, herniated disc, arthritis, and disc degeneration. Most adults older than 50 years have some degree of degenerative disc disease, although they may not be symptomatic. Now, women have a higher incidence of low back pain compared to men. Acute back pain usually results from injury or trauma, such as during a fall or vehicular crash or when lifting a heavy object. I want to make a stop here. So nurses, you need to work on your body mechanic. When you are going to work in the hospital, you are going to be asked to lift, to transfer patients, to maybe reposition a patient on the bed. If you don't know your correct body mechanics, you're gonna end up like Professor Matalana. I have a spinal stenosis, okay? Because I was so into helping my patients, and sometimes I didn't ask for a second nurse to help me with the transitioning or transferring from bed to the wheelchair. I was working in a rehab unit, and sometimes I have to help patients that the weight was more than 300 pounds. and I was doing it myself. Okay, so body mechanics, body mechanics. Okay, where I was. Acute pain, and usually women. Why women more than men? Because think all the times that when we have to carry the kids, you know, our babies, and we are lifting baby from the floor or doing different activities, and we are lifting or maybe pushing sofas or lifting the shopping bags or grocery, you know, different types of objects that we usually lift. That's why women, we perform these activities more often than men. Okay, acute back pain usually results from injury or trauma, such as during a fall or vehicular crash or when lifting a heavy object. Perfect. The mechanisms of injury include repetitive flexion and or extension and hyperflexion or hyperextension with or without rotation. Obesity places increased stress on the vertebral column and back muscles, contributing to risk for injury. And that's one of the reasons I have to lose 66 pounds. So I was not taking care of my body mechanics. I was obese, right? So all these factors put our spinal cord in risk. Okay, smoking has been linked to disc degeneration and scoliosis. An abnormal lateral curvature of the spine can also lead to low back pain at any age. Okay, so that's why during class, I'm always going to suggest you to eat healthy, proper nutrition, proper fluids intake, and like we are making fun of our squats, but little by little, I am introducing the habit for you, and that you need to practice more sports, guys. And it's that because based on my experience, learn from my experience, you don't want to have a chronic low back pain, okay, especially now in nursing. Your first year is going to be the most difficult, and it's the year that you need to adapt and you need to take care of yourself. So patient care. Vertebral fracture from osteoporosis contributes to low back pain. Okay, so we also have other factors that can cause low back pain in the older adult include spinal stenosis, osteoarthritis, osteoporosis, scoliosis. Osteoarthritis, you need to think about the nutrition. You have try to avoid products that are going to cause inflammation to your entire system, because inflammation is the cause of all the diseases that ends on itis, osteoarthritis, hepatitis, and many on the list. So try to eat healthy. Okay, also scoliosis, intervertebral disc degeneration. Health promotion and disease prevention, basically with proper posture and exercise, can significantly decrease the incidence of low back pain. So proper posture, as I was mentioning, body mechanics, exercise, walking, do any type of exercise, walking, riding your bicycle, maybe swimming, right? Ergonomics is an applied science in which the workplace is designed to increase worker comfort, thus reducing injury while increasing efficiency and productivity. An example is a sitting lift designed to help nurses assist patients to get out of bed. A variety of equipment can be used to decrease injury related to moving patients. Okay. Patient and family education, prevention of low back pain and injury. Participate in regular exercise program, especially one that promotes back strengthening, such as swimming and walking. Yes, what I just mentioned. Do not wear high heel shoes. Oh my god, this is the part that I don't like because I love to wear my high heels. But yes, the first day, for example, that I taught your class, Nurse 201, I was wearing my, 2-3 inches high heels. And then after the class ended, I felt like I was dying. I couldn't even get back to my car. I was gonna call Uber. Anyway, use good posture when sitting, standing, and walking. Avoid prolonged sitting or standing. Use footstool or ergonomic chairs and tables to lessen back strain. Be sure that equipment in the workplace is ergonomically designed to prevent injury. And right now, recently, I bought my standing desk, so I change positions continuously. I have one in the office, and here at home I have a small one that I can put on top of my desk, and it's gonna go up and down. So basically, and sometimes while I am recording your lectures, I am standing up, right? Some other times I am sitting. Keep weight within 10% of ideal body weight. So I would say take control, measure your BMI, get your BMI, and then you can see if you are above that 10% of the ideal body weight. Ensure adequate calcium intake. Consider vitamin D supplementation if serum levels are low. Of course, vitamin D, always including calcium, or you always check your levels through blood work with your primary care, and then that way you can decide your dosage, proper appropriate dosage of calcium and vitamin D. Stop smoking. If you are not able to stop, cut down on the number of cigarettes or decrease the use of other forms of tobacco. Who's smoking nowadays? It's not, you know, it's not healthy anymore. Avoid lifting patients or equipment to prevent back injury. Again, you're going to be in healthcare. You're going to work with overweight or obese patients. You're going to work with the elderly population, and they need a lot of help. So always, especially in your first year, until you get used with the protocols and all the pharmacologic and all the procedures that from different diseases and protocols from different units, always ask the help for a CNA of another nurse. Recognize cues assessment. The patient's primary concern is continuous pain. Some patients have so much pain that they walk in a stiff, flexed posture, or they may be unable to bend at all. Yes, they may walk with a limp, indicating possible sciatic nerve impairment. Your pain assessment, please complete your pain assessment, pain score, use your old car mnemonics, right? When this pain started, what is the location, is cervical, is lumbar, is sacral, the duration, for how long you have been with this pain, maybe 3 years, 4 years. Remember that after 3 months is already considered chronic. What is the characteristic? Is this a sharp pain? Is this tingling, numbing? What alleviates this pain? A is alleviates. R, um, what is alleviate, relieving, and I forgot. Is characteristic, relieving, and precipitating factors. The T is timing. For example, when you get the pain, for how many minutes, how many hours, and the severity from 0 to 10, for example, how painful it is. So you complete your pain score. Determine whether a recent injury to the back has occurred. Is it not unusual for the pain to say, I just moved to do something and felt my back go out? Inspect the patient's back for vertebral alignment and tenderness. Patients will often describe pain as stabbing and continuous in the muscle closest to the affected disc. They often describe a sharp burning posterior thigh or calf pain that may radiate to the ankle or toes along the path of one or more spinal nerves. The pain is often aggravated by sneezing, coughing, or straining, and that's very common. Driving a vehicle is particularly painful. Okay, so if the sciatic nerve is compressed, severe pain usually occurs when the patient's legs is held straight and lifted upward. To complete the neurologic assessment, evaluate the patient's muscle tone and strength. Muscle in the extremity or lower back can atrophy as a result of severe persistent back pain. Ask patients whether they have frequent feelings or sadness or have considered suicide. For many patients, persistent pain can cause depression and or suicidal ideation. And that's why it's very important. I'm going to tell you something. Patients are going to disclosure the pain score, but it's very hard for a patient to admit that they are having depression or suicidal thoughts. So by knowing the pain score, you can anticipate if this patient is in risk for suicide. Okay, and that's good to know. NCLEX alert. Okay, imaging studies for patients who report mild non-specific back pain may not be done depending on the nature of the pain. Patients with severe or progressive motor or sensory perception deficits or who are thought to have other underlying conditions like cancer or infection require complete diagnostic assessment. So a number of diagnostics includes of course, first in line is going to be the x-rays, then the CT scan, then the MRI. Bone scan shows bone changes after injection of radioactive tracers, which attach to areas of increased bone production or show increased vascularity associated with tumor or infection. Electrodiagnostic testing such as electromyography, EMG, and nerve conduction studies may help distinguish motor neuron diseases from peripheral neuropathy or radiculopathy, which is a spinal nerve root involvement. Radiculopathy, okay, is related to the spinal nerve root. These tests are especially useful in chronic diseases of the spinal cord or associated nerves. Take actions, interventions. Management of patients with low back pain varies, of course, depending on the severity and chronicity of the problem. Most patients with acute low back pain experience a spontaneous resolution of pain and other symptoms in less than 3 months. So 3 months is the, let's say, is kind of the border for recognizes this pain as chronic or acute. Some patients need only a brief treatment regimen of at-home exercise or physical therapy to manage pain. Some patients have continuous or intermittent chronic pain that must be managed for an extended period. Referral to an interprofessional team that specializes in pain or back pain can provide expert long-term management. Non-surgical management for patients with acute, non-specific low back pain. Non-pharmacologic measures are often the first line treatment. So they are going to have their NSAIDs, they're going to get naproxen. Although a recent clinical guideline published by the North American Spine Society found insufficient evidence to support many of the most commonly recommended treatments. Okay, so what are the effective treatments then? Physical therapy can help strengthening surrounding muscles. Ultrasound treatments, transcutaneous electrical nerve stimulation, TINS, laser therapy, traction, dry needling, acupuncture, bracing, or massage therapies. Although all these treatments are being recognized by patients that are providing some relief. The North American Spine Society, they manifest they don't have enough evidence, conclusive evidence to endorse all these therapies, right? So multiple opinions are based on severity. The patient should begin stretching exercises and resume normal daily activities as soon as possible. Yes, if the pain is not 9 out of 10. Aerobic exercise has good evidence to support its use when the patient is able. Of course, most patients also find that they need to change position frequently, and I think that is one of the best therapies. So if you are sitting, don't stay more than 30 minutes. Even if you stand up for 1 minute, that is going to relieve the pain and the pressure. So walk around 1 second, 10 seconds, go for a glass of water, come back, have a seat again. So changing position is good. Prolonged sitting, standing, or lying down increases back pain. Yes, I experienced that myself. The Williams position is typically more comfortable and therapeutic for the patient with acute low back pain from a bulging or herniated disc. In this position, the patient lies in semi-Fowler position with a pillow under the knees. So semi-Fowler, you know, probably is going to have a pillow or two pillows under the neck, and then, or it's going to be, it's called like 30 degrees angle or 45 degrees angle. And also you're going to have a pillow under the knees to keep them flexed, or sits in a recliner chair. I'm going to submit an image for this William position so you are clear on this. This position relaxes the muscle of the lower back and relieves pressure on the spinal nerve root. And those materials are in the supplemental file with this chapter. So, but besides that, we are going to watch a video about the Williams flexion exercise. So they have a Williams position, but also they have the exercise that I'm assuming is gonna be beneficial for you guys to watch. So let me play the video.
Hey guys, we've got a new exercise for you guys to do today, Williams flexion exercises. So a lot of times we look at the back and we know about like back injuries with regards to your lumbar discs or your muscles, but one of the things that we kind of look at is the facet joints, which that's actually what we're adjusting whenever we're treating patients, is we're getting the motion segments in each one of your spine segments to actually keep moving. And so the Williams flexion exercises are great whenever you have lower back pain that seems to hurt whenever you're kind of coming backwards this way, and it's just causing more impaction and everything that you're feeling in that back. Sometimes it's just local, but it's usually sharp and pretty intense when you feel it. So this is going to be a great exercise for everybody to kind of use to be able to get through this if you feel like it's kind of a little bit off and before you can get to your next appointment. So I'm going to start today. It's broken down into a couple different segments based off the severity where you're at. So where we always start patients is whenever they're laying flat like this, bringing their legs down at their side, or completely flat and stretched out. And what you're going to do is bring one knee towards your chest like so. So from this point, you are getting a little bit of flexion to be induced into the actual back itself by moving that pelvis. You're going to hold this stretch for about 15 seconds or so, just enough to kind of start feeling the muscles relax. Most of it you should feel in this area, right through the glutes and everything else. We want to stretch those as well. We hold this for 15 seconds, and then we're going to switch legs, come back the opposite side. So we start here whenever we're really, really bad, but even if you're not in extreme pain, this is a good place to start to just kind of loosen everything up. Once you get both sides done, you're going to bring double knees to chest. Hold it just like this, and you're going to feel a lot more stretch to start to happen in that lower back. The double knees to chest is a great exercise, and so we're just kind of getting through the series right here. When you feel like that's kind of rocked out for about 15 seconds, you're going to sit up, stretch out this way, and then using your core, you're going to bend at the waist as much as you can and bend forward. Now this may be the kind of line that you draw depending on the severity of the pain. If you're in really bad symptoms right there, you may not be able to go much beyond this. Again, if this is causing more pain, you want to step back, and we may have to go the other way and stretch opposite way. Check out your McKenzie extension exercises if that's what's going on. So as we're getting that back to loosen up this way, we're getting more and more motion in those vertebral segments. So the next progression that we come to, we're coming to a seated position. This is a little bit high for me, but you can see what we're doing. You're going to slowly start to hip hinge and move downwards towards the ground, leaving it in this position, and then slowly starting to walk back. What I would suggest is waiting about 15 seconds in each position, so that way you're getting plenty of time for you to get to that spot, allow your back to readjust to there and those muscles to lengthen. It may require you to do multiple reps at that same location before you move on to the next progression. So kind of play with it, see what actually is working for you in that motion or in that moment. But yeah, these are great exercises. We really want you to kind of be able to use this if you ever have a hot low back or it's on the weekend, you can't get in, but this is a good thing for you to have in your a tool in your tool basket. So check out some of our other stretch videos and see if you can do some of those today too. All right, take care.
Thank you. So I was given these routine exercises in the physical therapy. I'm practicing those and they are really helpful. I'm also doing the walking, the swimming, and I lost weight. And sometimes when it's very painful, which is from 0 to 10, sometimes a level 4, I get my NSAIDs. But nurses, please, prevention, prevention, prevention. Use your body mechanics. Try to lose weight if you have above that extra 10%. And do your walking. Okay, if you cannot do aerobics or you don't have the time to register on a gym, or there are multiple ways that you can exercise, and it's all about prevention. I don't want you right now that you're studying and you're sitting for long periods. You are a high risk. You're a good candidate for these injuries, okay, and back pain. Okay, let's continue. So we saw the video. The National American Spine Society was unable to find conclusive evidence that sleep quality, smoking, or obesity were predictive of a chronic condition. Okay, I'm just following information that the book is providing. So far, I was trying to get something good evidence from this society, or probably any good suggestion what to practice. Let's see if there is something else in the next paragraphs. Patients may benefit from complementary and integrative therapies such as stress reduction, mindfulness, progressive muscle relaxation, and yoga. Yes, because at the end, what we are dealing is with a spinal cord, which is a cord full of nerves, and the nerves are influenced by stress, anxiety, blah, blah, blah. So all these integrative therapies can help somehow. Cognitive behavioral therapy, in addition to physical therapy, had strong evidence to support its use in patients whose pain continues beyond 12 months. Cognitive behavioral therapy. Oh, okay. So here we have one. Non-selective NSAIDs such as aspirin, ibuprofen, and naproxen are helpful, yes, although antidepressants and antiepileptics such as gabapentin are often prescribed. The National Association of Spinal Society, is that the name? National Association, North American Spine Society does not recommend them in the treatment of low back pain. In the other hand, patients with chronic pain may become depressed. In that case, antidepressants are appropriate. So this society also found insufficient evidence for treatment with steroids. Yes, because the steroids is gonna relax the inflammation, and you're gonna become dependent of the steroids. You don't want to become dependent of that, right? So it's better to practice your walking, your swimming, changes in position, your physical therapy. Siconotide is a potent analgesic sometimes used for patients who have severe persistent pain. Muscle spasm can occur, for which the provider may prescribe centrally acting muscle relaxant. Commonly used medications include diazepam, cyclobenzaprine, metaxalone, carisoprodol, and tesanidine. So safety, safety, safety. Nursing safety priority. All central acting muscle relaxants can cause, and what are the relaxants? Diazepam, cyclobenzaprine, blah, blah, blah. They can cause sedation, dizziness, or lightheadedness. Most muscle relaxants have anticholinergic properties, meaning they are going to cause dry mouth, urinary retention, which is not nice. It can affect your heart, blurred vision, constipation, which is not nice, and tachycardia. So these side effects plus sedation increase in older adults' fall risks and should therefore be avoided in this population. And of course, if you are taking this, you have to avoid driving. Siconotide should not be given to patients with severe mental health, behavioral health, because problems can, side effects of this medication can cause psychosis. Oh, wow, this is better. Imagine somebody with a low back pain and they ended up being psychotic. If symptoms such as hallucination and delusion occur, teach patient to stop the drug immediately. This is an NCLEX alert. You need to know this. A physical therapist, the type of exercises prescribed depends on the location and nature of the injury and the type of pain. So the physical therapy is going to prepare an exercise program based on the location and nature of injury. McKenzie exercises are often utilized to help reposition the misaligned vertebral disc, strengthening surrounding muscles, and teach the patient how to manage back or neck pain themselves. So the most important is that you cannot start your McKenzie exercises until acute pain is reduced by other means. So you have to have a lower level of pain, like 2 or maybe 1, and then you start your McKenzie exercises. Let's watch this video. It's a very short video, and you're going to understand why you need to be almost pain-free to start this routine. So you see how the hyperflexion on the lumbar sacral, okay, can cause more pain. So that's why they are asking you to be almost pain-free. This is kind of the same of the Williams exercises, right? But you don't have to put your hands backwards in between your legs. There is a lot of hyperextension and extension. me, that's one of the best ones. This one is excellent. Excellent. Thank you so much. And you have the full series and the full link for these exercises in your supplemental file. So also, water therapy combined with exercise is helpful. Muscle resistance during exercise will prevent atrophy. Weight reduction may help reduce persistent low back pain by decreasing the strain on the vertebrae caused by excess weight. If the patient weight exceeds the ideal by more than 10%, calorie restriction is considered. Although our National American Spine Society found insufficient evidence with in relation with BMI as a predictor for recurrent back pain. Okay, so in I can testify, I can give testimony that my discomfort, my pain has reduced significantly after I lost 66 pounds, practice walking, swimming, doing my physical therapy, okay, and occasionally taking my NSAIDs if necessary after a party that I wear my high heels, for example. Surgical management. If conservative measures fail to relieve persistent back pain, or if neurologic deficits continue to progress, an orthopedic surgeon or a neurosurgeon perform these surgeries. Minimally invasive surgery and conventional open surgical procedures are done, and MIS, minimal invasive surgery, is not done if the disc is pressing onto the spinal cord, central cord involvement. Preoperative care, teach the patient about postoperative expectation depending on surgical method, includes techniques to get into and out of bed, turning and moving in bed, immediately reporting new sensory perceptions such as numbness and tingling, or new motor impairment that may occur in the affected leg or in both legs, home care activities and restriction, if any. Make sure that patients understand the type of procedure they are having and the postoperative care they will be needed. Postoperative procedures in MIS using endoscopy or percutaneous instrumentation results in minimal muscle injury, decreased blood loss, and decreased postoperative pain. And this is done in ambulatory care the same day and they go home. Spinal cord and nerve complications are also less likely. This is in the case of minimal invasive surgery. If a microdiscectomy is performed, this involves microscopic surgery directly through a 1-inch incision using an endoscope. So it's getting more specialized, right? A special cutting tool or laser probe is threaded through the cannula for removal. This is an invasive surgery, right? Through a small cutting, 1-inch incision. So the laser probe is threaded through the cannula for removal or destruction of the disc pieces that are compressing the nerve root. This process is also called a percutaneous endoscopic discectomy. A newer procedure combines the percutaneous endoscopic discectomy with laser thermodiscectomy to also shrink the herniated disc before the removal. Inpatient hospitalization is not necessary for this procedure. Another is laser-assisted laparoscopic lumbar discectomy. It combines a laser with modified standard disc instruments inserted through the laparoscope using an umbilical belly button incision. So they perform the surgery through the belly button. The procedure may be used to treat herniated discs that are bulging but do not involve the vertebral canal. The primary risks for this surgery are infections and nerve root injury, and that's good to know. Infection precautions has to be in place, okay? So the newest addition to the minimal invasive surgery procedures is robot-assisted spinal surgery. And they are using robots for everything nowadays. This procedure requires additional training and experience for by the surgeon, right? The most common upper surgical procedure are discectomy. Discectomy means the removal of the discotomy, right? Removal. Laminectomy, in which are going to remove the laminae that is part of the vertebrae, or spinal fusion. These procedures involve a surgical incision to expose anatomic landmarks for extensive muscle and soft tissue dissection. Discectomy is removal of a herniated disc, and laminectomy involves removal of part of the laminae and facet joints to obtain access to the disc space. Spinal fusion connects two or more vertebrae to stabilize the spine and release compression of the spinal nerves. And that's the one I want you to remember, the concept of spinal fusion that connects two or more vertebrae to stabilize the spine and release compression on spinal nerves. So let's going to watch this video about the spinal fusion. Okay, here we go. And maybe I'm going to accelerate the video.
Spinal fusion is performed on the spine to weld two or more vertebrae together using surgical hardware and bone graft material. The spine consists of a series of interconnected bones called vertebrae, extending from the base of the skull to the tailbone. Each vertebra connects with the one above and below at the facet joints, allowing them to move relative to one another. In between each bony vertebra lies a shock-absorbing intervertebral disc. The facet joints and intervertebral discs work together to permit the bending and twisting motions of the back and neck. Protected within the vertebral column is the spinal cord, which connects the brain to the rest of the body. Spinal nerves emanate from the spinal cord at regular intervals. Your doctor may recommend spinal fusion if you have one of the following conditions: a fractured vertebra, excessive motion between vertebrae causing instability and pain, spondylosis, a degenerative arthritic condition that may cause loss of normal spinal structure and function, or spondylolisthesis, a condition in which one vertebra slips forward relative to the one next to it. Other conditions that may require surgery include osteoarthritis of the facet joints, a spinal deformity such as scoliosis or kyphosis, or a bulging or herniated disc, which can press on the exiting spinal nerve. Spinal fusion is designed to eliminate movement between the affected vertebrae, making the spine more stable and decreasing pain. Before your procedure, an intravenous line will be started. A catheter may be placed in your bladder to drain your urine. Spinal fusions are done under general anesthesia, which means you will be asleep for the duration of the operation.
Oh, perfect.
A breathing tube will be inserted through your mouth and into your windpipe to help you breathe during the procedure. If your surgeon is using your own bone for the fusion, he or she will make an incision overlying your hip and remove a bone graft. If your bone graft is coming from another donor, it will be harvested prior to your procedure. If you're having an open procedure on the lumbar spine and your lower back, you will lie on your stomach and your surgeon will make an incision directly over the spine. If you are having surgery on the cervical spine and the neck, your surgeon will generally approach this area from the front. In some cases, a spinal fusion may be performed using a newer, less invasive laparoscopic technique. Rather than 1 or 2 large incisions, a laparoscopic spinal fusion requires several tiny keyhole incisions, through which the laparoscope and special surgical instruments are inserted. Using a high-speed drill and other instruments, your surgeon will remove the disc between the 2 vertebral bodies to be fused. Next, your surgeon will insert the bone graft into the space between these 2 vertebrae. He or she may also place a plate and screws over the graft to hold the vertebrae together until they fuse into one bone.
Oh, wow.
To complete the procedure, your surgeon will close the deep tissue and skin incision with stitches. Many surgeons will also place 1 or more drains beneath the skin that will remain in place for a few days. After your procedure, you'll be taken to a recovery area for monitoring. The bladder catheter will likely remain in place for several days. You may be unable to eat for a day or 2 after surgery and will receive fluids and nutrition through the IV. Some pain is expected during the first few days following surgery, and you will be provided with pain medication to control it.
Wow, this video was excellent. So the last procedure they show with the cervical, and is done in the front, is the anterior anterior approach of the cervical. So for that procedure, and we're going to talk about that later, for that procedure you need to monitor for respiration, you need to monitor if the patient is able to swallow, breathing, hoarse voice. Okay, keep in mind that. Okay. Post-operative depends on the surgical method and procedure that was performed. In the post-anesthesia care, you need PACU, vital signs, and level of consciousness are monitored frequently as for any other surgery. Yes, just getting to that happen. All the vital signs and level of consciousness you need to assess like exactly as for any other surgery. Patient who have a minimally invasive spinal surgery go home the same day or the day after the surgery with 1 or more wound closure tapes over the small incision. Those having a microdiscectomy may also have a clear or gauze dressing over the bandage. Most patients notice less pain immediately after surgery, but mild oral analgesics are needed while nerve tissue heals over the next few weeks to promote patient comfort. Teach the patient to follow the prescribed exercise program. Start walking routinely every day. Walking is so good in general for everything. As for many patients undergoing surgery, take vital signs at least 4 hours during the first 24 hours to assess for fever, hypotension, or severe pain. Perform neurologic assessment every 4 hours. Of particular importance are movement, strength, and sensory perception in the lower extremities. Careful check the patient's ability to void after urinary catheter removal. Remember that all these nerves are having effect and in the bladder and the bowels, right? So you need to check for proper function. An ability to void may indicate damage to the sacral spinal nerves, of course. The patient with an open traditional discectomy, laminectomy, and or traditional open spinal fusion typically gets out of bed with assistance on the evening or of the surgery, which may help with voiding, and that's good to know, and also that will prevent any thrombus, right? We don't want to get thrombus. Assessing and management the patient with major complications of open traditional lumbar spinal surgery. Complications, cerebrospinal fluid, and this is NCLEX alert, okay? And I think I'm going to test you on this. I don't know if on this exam, but probably on the final or maybe on the quizzes. So observe for clear fluid or on around the dressing. If leakage occur, place immediately the patient flat because you want to avoid the fluid leakage, right? The cerebrospinal fluid leakage. And immediately report. Fluid volume deficit, monitor intake and output, assess for dehydration, monitor vital signs, skin turgor, hypotension and tachycardia, acute urinary retention, assist the patient to the bathroom or bedside commode as possible after surgery or urinary catheter removal. Help male patients stand at the bedside as soon as possible after surgery or urinary catheter removal. Paralytic ileus, this is another big one. Monitor for flatus or stool, assess for abdominal distension, nausea and vomiting. Remember the nerves that are in charge for bowel movements. Fat embolism, this is another NCLEX maximum alert. Fat embolism syndrome, more common in people with traditional open spinal fusion. Observe for and report chest pain, dyspnea, anxiety, and mental status changes. Note that petechiae around the neck, upper chest, buccal membrane, and conjunctiva is the typical presentation of fat embolism. Petechiae, petechiae, petechiae. Persistent or progressive lumbar radiculopathy. Remember that the radiculopathy means that there is a pain caused by the nerve. Report pain not responsive for analgesics. Infection, wound, discs, hematoma, monitor for patient's temperature, careful. So for infection, temperature, redness, swelling, pain, okay? And give antibiotic. The big ones here are fat embolism and cerebrospinal fluid leakage, okay? Very careful, and paralytic ileus. So critical rescue for the patients after back surgery. Suspect the surgical dressing for blood. You need to inspect for blood or any other type of drainage. Clear drainage may mean cerebrospinal fluid leakage. Blood and CFS, cerebrospinal fluid, may be mixed on dressing with the CSF being visible as a halo around the outer edges of the dressing. Be careful with that. The loss of a large amount of CSF may cause the patient to report having a sudden headache, and this is the classic presentation of cerebral spinal fluid leakage. If CFS leak is suspected, keep the patient on bed rest and lower the head of the bed immediately to slow the loss of fluid. Report signs and symptoms of drainage to the surgeon and the rapid response team, because this is an emergency. Check the bulging of the incision, and that the incision may be due to bulging at the incision site, may be due to a CSF leak or a hematoma, both of which should also be reported immediately. This is maximum NCLEX alert. What is it here? Is this a maximum NCLEX alert? Safety, safety, safety. Teach the patient to lock. If you, in terms of mobility, the proper way is to ask the patient to lock roll every 2 hours from side to side, side to back, and vice versa. In log rolling, the patient turns as a unit while the back is kept as straight as possible. A turning sheet may be used for a obese patient, but always get additional assistance depending on the case of the patient and the weight. Prevention of BTE. Follow best practices to avoid venous thromboembolism after surgery with early mobility, intermittent sequential compression or pneumatic devices, and anticoagulant therapy. So patients that are going to transition to other type of care, either home or they're going to a nursing home, whatever, rehabilitation unit. Patients having any MIS, minimal invasive surgery procedures, or a lumbar interbody fusion may resume normal activities within a few days up to 3 weeks after surgery, depending on the specific procedures and the condition of the patient. The patient may take a shower on the third or fourth day after surgery. So if you're a nurse and the patient is staying in the hospital, just wash the patient with these towels, warm towels. Teach the patient to leave the wound closure tapes in place for removal by the surgeon or until they fall off. Instruct the patient to contact the primary healthcare provider immediately if clear drainage seeps from the incision. Clear drainage usually indicates a dural tear and the cerebrospinal fluid is leaking. After conventional open lumbar surgery, the patient may have activity restrictions and recommendations the first 4 to 6 weeks, such as limit daily stair climbing, of course, because it's causing a flexion or hyperflexion, depending in that area. Restrict or limit driving. Do not lift objects heavier than 5 pounds. Restrict pushing and pulling activities, which is dog walking. Avoid bending and twisting at the waist. Take a daily walk. The patient may wear a back orthotic device for up to 6 weeks. And provide information about the importance of wearing the brace as instructed during the healing process. Continue taking anti-inflammatory drugs or muscle and other therapies if muscle spasm is present. Could be muscle relaxant, but you have to remember the family and the patient about the side effects we spoke a few minutes before. In a few patients, back surgery is unsuccessful. This could happen, and it's happening. This situation, referred to as failed back surgery syndrome, is a complex combination of organic, psychological, and socioeconomic factors. Repeated surgical procedures often discourage this patient, who must continue aggressive pain management after multiple operations. And sometimes physical therapy does not cover the full series of days for treatments. Spinal cord stimulation. So this patient, become drug dependent. They have to keep taking drugs and strong opiates. Spinal cord stimulation is an invasive technique that provides persistent pain relief by applying an electrical field over the spinal cord. Electrodes are surgically placed internally in the epidural space and connected to an external or implanted programmable generator, like the deep brain stimulator or something similar to that. The patient is taught to program and adjust the device to maximize comfort. Alert, alert, alert. For patients who have a spinal cord stimulator implanted in the epidural space, assess neurologic status below the level of the insertion frequently. Monitor for early changes in sensory perception, movement, and muscle strength. Ensure that the patient can void without difficulty. We finished already with the low back pain. We are moving to the last topic, cervical neck pain. Almost done with the chapter. Breathe, relax. We are almost done. Cervical neck pain most often results from a bulging or herniation of the nucleus pulpus in a cervical intervertebral disc. We already saw on a previous video of spinal fusion what is the nucleus pulpus. So this is another video if you want to watch it. Is in the supplemental file. I'm gonna keep moving, we're almost done, and this is a repetitive, but this video is only related to the cervical pain, okay? Pathophysiology review. The result of the cervical herniation of the nucleus pulpus is a spinal nerve root compression with motor and sensory manifestations and moderate to severe pain, typically in the neck, upper back, over the shoulder, and down the affected arm. The disc between the fifth and sixth cervical vertebrae is affected most often. The fifth and the sixth disc in the cervical vertebrae. Cervical pain, acute or persistent, can also occur from muscle strain, ligament sprain resulting from aging, poor posture, And this is you nurses, your body mechanic. Lifting, you nurses, tumor, rheumatoid arthritis, osteoarthritis, or infection. The typical history of the patient includes a report of pain and numbness or tingling when moving the neck, which radiates to the shoulder and down the arm. And sometimes it could be mistaken with carpal tunnel syndrome, which is a condition of the nerve that is a close, it goes through the wrist, right? The pain may interrupt sleep and may be accompanied by a headache or numbness and tingling in the affected arm. Electromyography, nerve conduction studies. Electromyography, a study of the muscles with some electricity. Electromyography, nerve conduction studies are used to help differentiate cervical radiculopathy. Cervical or any radiculopathy means that the pain is coming directly from the nerve. In this case, is the cervical nerve. Ulnar or radial neuropathy, which is related to the arms. There you go, carpal tunnel syndrome or other peripheral nerves problems. So interprofessional collaborative care, conservative treatment for acute neck pain is the same as described for low back pain, except prescribed exercises focus on the shoulders and neck. The physical therapist teaches the patient the correct techniques for performing shoulder shrug, shoulder squeeze, and seated rowing. Some primary health care providers prescribe a soft collar to stabilize the neck, especially at night. Believe it or not, at night is the moment in which we really use and abuse of our neck, and the pillow sometimes, instead of helping, is creating bad habits. So minimally invasive surgery or conventional open surgery is going to be performed. A neurosurgeon usually performs this surgery because of the complexity of the nerves and other structures in that area of the spine. So for open procedures, and depending on the cause and the location of the disc herniation, either an anterior or posterior surgical approach is used. Again, when we saw the previous video about spinal fusion, we saw the anterior approach for the cervical spine surgery, right? They cut in the front, and we were talking about that we need to monitor for hoarse voice, if breathing and respiration is okay. You need to monitor if the patient is able to swallow. Okay, is the anterior. So all these systems in between the vertebrae and the trachea are involved. Okay, so anterior or lateral interbody cervical fusion or lateral. Okay, in these procedures, a titanium mesh device is implanted into the space where the cervical disc was removed. We saw that in the video, and several screws ensure stabilization. For clients who have multiple cervical disc herniation and traditional anterior cervical discectomy and fusion, and we know discectomy is the removal of the disc, and fusion is either putting a new part of bone taken from the iliac crest and put some plates on top with some screws to make this area stabilize. With bone grafting may be performed, yes, as we described. This surgery is much more complex and causes more postoperative complication than the anterior interbody cervical fusion or lateral interbody cervical fusion. The patient having traditional anterior cervical discectomy and fusion usually wears off a soft collar for about 2 to 3 weeks after surgery. So here comes the safety part. The priority for care in the immediate postoperative period of the anterior cervical discectomy fusion is maintaining an airway and ensuring that the patient has no problem with breathing. Yes. Swelling from the surgery can narrow the trachea. Yes. Causing a partial obstruction. Yes. So that's good to know. NCLEX alert. Surgery can also interfere with cranial innervation for swallowing. It's the area, it's that area, right? So it's logical, it's critical thinking, nurses, resulting in a compromised airway or aspiration. If the changes occur, open the patient's airway, sit the patient upright, suction if needed, and provide supplemental oxygen. Yeah, this is it's obvious, right? It's common sense. So best practice for patient safety and quality care of the patient after a traditional anterior cervical discectomy and fusion. Post-operative intervention, assess airway, breathing, and circulation. That's your first priority. Like with any other surgery, nurses, do your assessment, complete assessment, including your neurovascular, and you're gonna be safe. Check for swallowing ability in this case because that is a particular area. Bleeding, your neurostatus, as I mentioned, all your vital signs, assess for pain, as the patient assist the patient with ambulation to prevent venous thromboembolism, discharge teaching, review activity restrictions, no lifting, of course, no driving until surgeon permission received, no strenuous exercises, walk every day, call the surgeon if symptoms of pain, numbness, and tingling worsen, or if swallowing becomes difficult. This is a big wear collar per the primary healthcare provider prescription, and some patients are candidates for minimally invasive surgery, such as percutaneous cervical discectomy through an endoscope with or without laser thermodiscectomy to shrink the herniated portion of the disc. The care for these patients is very similar to that for the patient with low back pain who has minimal invasive surgery. Ladies and gentlemen, we have concluded chapter 40 from your 10th edition, which is, I think, chapter 37 from the 11th edition, and the exam is going to be until here. Okay, good luck. Thank you for your attention, and see you the day of exam.